Hello, welcome to this presentation about approach to chest radiograph. This presentation is prepared by Radiology Department Hospital Kulim. Hope you will enjoy it. Chest X-ray is the most frequently requested radiologic examination. The interpretation of a chest radiograph requires the understanding of basic principles. In this presentation, I will focus on the systemic approach to the chest radiograph. Before interpreting the radiographs, there are a few things we need to do. First, verify the patient's identity. Make sure that it's the correct patient and correct examination. Check the X-ray view and assess the film quality by analyzing the film collimation, exposure or penetration, patient's positioning, and inspiratory effort. PA or AP view chest radiograph is the most commonly requested by clinician in daily practice. AP and PA view X-rays look similar, but they are different. Without the X-ray marker, we should still be able to differentiate between AP and PA views. How can we differentiate them? This table shows the difference between the PA and AP view. The PA view chest radiograph is acquired with the patient standing, both elbows flexed with the dorsal of both palms resting on the hip. Therefore, on PA view, the scapulas are more lateral, outside the lung fields. The clavicles are more vertical and the anterior ribs are more prominent. The heart is less magnified. The AP view chest radiograph is acquired in a sitting or supine position. So the scapulas overlap with the lung fields, the clavicles are more horizontal. The posterior ribs are more prominent and the heart is manifold. Heart size is better assessed on PA view. This is because the heart is at a greater distance from the film, hence it appears more manifold in AP view. Next, we should assess the image quality. Optimal radiograph quality provides better diagnostic accuracy. There are four main factors that determine the technical quality of the chest radiographs, which include collimation, penetration or exposure, the patient's position, and the inspiratory effort. Let's go into details one by one. First, collimation. Collimation means restricting the X-ray beam to the region of interest. An optimally collimated chest radiograph should include the lung apices, bilateral costophrenic angles, and lateral syn margins. Second, exposure or penetration. The X-ray on the left is an overexposed film. The X-ray in the middle is optimally exposed. And the X-ray on the right is an underexposed film. On an overexposed film, the heart is more radiolucent. Lungs become proportionally darker and often give the appearance of lacking lung tissue, as would be seen in a condition such as emphysema. On the contrary, on an underexposed film, the heart is more opaque. The thoracic vertebrae are poorly seen, and the lungs may appear denser and wider, giving the appearance of infiltration. If the film is properly exposed, the lower thoracic vertebrae should be visible through the heart and the bronchovascular structures behind the heart should be seen. Next, positioning. There should be no rotation on a PA or AP chest radiograph. Patient rotation can be assessed by observing the distance between the clavicular head and the spinous process of the thoracic vertebra. Look at this X-ray. The patient is rotated to the right. The unfolded aorta mimics a mediastinal mass. Last, the patient's inspiratory effort. With adequate inspiration, the diaphragm should be seen at the level of the 5th to 6th anterior rib and the 10th posterior rib. The heart is apparently larger on an expiratory chest X-ray. The interpretation of chest radiographs should be approached systematically. A classical schematic of A, B, C, D, E, F, G, H can be used to guide the analysis. In order to recognize an abnormality, you need to know what a normal chest radiograph looks like. Let's start with A, the airway. The trachea, carina, and both main bronchi are called the upper airway and should all be visible on a chest X-ray. Look to see if there is any deviation of the trachea away from the midline. The normal carina angle ranges from 60 to 100 degrees. Widening of the carina angle suggests left atrial enlargement. Next, B, bone and soft tissue. A chest X-ray provides a good view to look for ribs and clavicle fractures. Each rib should be followed across its length to look for fracture lines or step-offs that could indicate a fracture. You should also check soft tissues outside the thorax for soft tissue mass, subcutaneous air, foreign body, bizarre density, etc. Nipple shadows are often seen on chest radiographs and can be easily confused for a pulmonary nodule. Nipple shadows are nodular opacities that are consistent in shape and symmetrical. Next, C. Cardiac. This part involves the heart and surrounding structures. The heart borders should be clear. The aortic arch and the left pulmonary artery should be visible as two semicircles above the left atrium. The AP window should be concave in the lateral border. If it is not, mediastinal lymphadenopathy and aorta or pulmonary artery aneurysms are possible. As a general rule, the heart base should not be wider than half the total width of the diaphragm. The cardiothoracic ratio is calculated by dividing the transverse cardiac diameter with the transverse thoracic diameter. A ratio of more than 0.5 indicates cardiomegaly. In ideal circumstances, mediastinum is maximum 6 cm in a PA chest X-ray, and further investigation is considered if it is more than 8 cm. D. Diaphragm. The outline of the diaphragm should be clear and smooth. Both diaphragms should form a sharp margin with the lateral chest wall. The highest point of the right dome is at 6th intercostal space anteriorly, ranging from the 4th to 7th ribs. The right dome is higher than the left by 2 cm, but the left may be higher than the right, especially with swallowed gas in the colon. E. Effusion. The pleural and pleural spaces will only be visible when there is an abnormality present. Pleural thickening, pneumothorax, or effusion. Pneumothorax can be life-threatening. A pneumothorax is, when looked for, usually easily appreciated on erect chest radiographs. They typically manifest as a peripheral lucent space with no lung marking visible beyond a very sharp thin white pleural line. F. Lung fields. On a chest radiograph, we divide each of the lungs into 3 zones, each occupying 1/3 of the height of the lung. Bear in mind that lung zones do not equate to lung lobes. Compare each zone between lungs, look for asymmetry. Do not forget to scrutinize the hidden areas. Pathology in the circled areas will be easily missed, which are the apex, hilar region, lung parenchyma posterior to the heart and diaphragm. Here's an example of a lesion in the hidden area. The right hemidiaphragm obscures a mass at the right lower lobe. G. Gastric bubble. We must check the X-ray position when we assess the gastric bubble. It can be seen on an erect X-ray. Beware of hiatus hernia and look for free air. How can we differentiate a gastric bubble from a pneumoperitoneum? A normal gastric bubble is round or oval in shape with a thick upper wall. Sometimes the air fluid level or food content can be seen. Look at this X-ray. Is this perforation? This is pseudopneumoperitoneum, known as the Calais-Dede phenomenon. It refers to the transposition of the bowel between the liver and the diaphragm. An air-filled bowel may mimic free gas. Lastly, H. Hilum and mediastinum. Hilum consists primarily of major bronchi, pulmonary arteries and veins. The hilar point is where the upper lobe vein crosses the descending pulmonary artery. The right hilar point should be at the level of the lateral extent of the right 6th rib. And the left hilar point should be 1 cm higher than the right. Both hila should be similar size and density. Hilar enlargement reflects one of 4 types of pathology: lymphadenopathy, tumors, pulmonary venous hypertension, or pulmonary arterial hypertension. The X-ray on the left shows a case of lymphoma where the hilar nodes are enlarged. On the right, showing dilated pulmonary arteries due to pulmonary hypertension. An anomaly on the chest radiograph would not be missed as we move from A to H. When an abnormality is detected, we have to describe the abnormality, the pattern of it, and in most cases, a differential diagnosis can be given. To begin, differentiate between focal and diffuse disease, as this will lead to a different list of differentials. Then, describe the abnormality. Lung abnormalities are mostly present as areas of increased density, which can be divided into the following patterns: consolidation, interstitial, nodule or mass, or atelectasis. Any pathologic process that fills the alveoli with fluid, pus, blood, cells, including tumor cells, or other substances, resulting in lobar, diffuse, or multifocal ill-defined opacities, is referred to as consolidation. Pneumonia is by far the most common cause of consolidation. The disease usually starts within the alveoli and spreads from one alveolus to another. When it reaches a fissure, the spread stops there. The key findings on the X-ray are ill-defined homogeneous opacity obscuring vessels, silhouette sign, extension to the pleura or fissure, but not crossing it, and no volume loss. What is silhouette sign? The silhouette sign is somewhat of a misnomer and, in the true sense, actually denotes the loss of a silhouette. Thus, it is sometimes also known as loss of silhouette sign. In picture number 1, the pneumonia is located more posteriorly in the chest compared to the heart, and we still see the silhouette of the heart, so there is no loss of silhouette. In the second picture, the consolidation in the lingular segment appears to have the same water density as the heart. The normal silhouette of the left ventricle is lost. So, this is called the loss of silhouette sign. Air bronchogram refers to the phenomenon of air-filled bronchi being made visible by the opacification of surrounding alveoli. Air bronchograms will not be visible if the bronchi themselves are opacified. Interstitial disease is pathology centered in or around the pulmonary interstitium. This includes thickening of any of the interstitial compartments by blood, water, tumor, cells, fibrous disease, or any combination thereof. The thickening of the interstitium can be reticular, reticulonodular, or linear, where the predominant pattern is a result of the underlying pathological process. The reticular interstitial pattern refers to a complex network of curvilinear opacities that usually involves the lung diffusely. They can be subdivided by their size into fine, medium, or coarse. A reticulonodular interstitial pattern is produced by either overlap of reticular shadows or by the presence of reticular shadowing and pulmonary nodules. Pulmonary nodules are small, rounded opacities within the pulmonary interstitium. Pulmonary nodules can be classified according to size, morphology, and/or distribution. Next, nodule or mass. A pulmonary nodule is defined as a discrete, well-marginated, rounded opacity less than or equal to 3 cm in diameter that is completely surrounded by lung parenchyma, does not touch the hilum or mediastinum. Lesions larger than 3 cm are considered masses and are treated as malignancies until proven otherwise. How to differentiate between benign and malignant lesions? Generally, we can differentiate them based on the multiplicity, the morphology of the lesion, the presence of calcification, and the growth rate. A large, rapidly growing spiculated lung mass is highly suggestive of malignancy. Anyway, the differentials for lung nodules or mass are very broad. The differential diagnosis of a nodule is basically the same as that of a mass, except that the chance of malignancy increases with the size of the lesion. Lesions smaller than 3 cm are most commonly benign granulomas, while lesions larger than 3 cm are treated as malignancies until proven otherwise and are called masses. The differential diagnostic list of multiple masses is very long. The most important diagnoses are listed in the table. Sometimes it is difficult to differentiate multifocal consolidations from masses. Lastly, atelectasis. Atelectasis or lung collapse is the result of loss of air in a lung or part of the lung with subsequent volume loss due to airway obstruction or compression of the lung by pleural fluid or in pneumothorax. The key findings on the X-ray are sharply defined opacity obscuring vessels without air bronchogram and volume loss resulting in displacement of diaphragm, fissures, hilar or mediastinum. These are the examples of lobar atelectasis. Plate-like atelectasis is a common finding on chest X-rays and detected almost every day. They are characterized by linear shadows of increased density at the lung bases. They are usually horizontal, measure 1 to 3 mm in thickness and are only a few cm long. In most cases these findings have no clinical significance and are seen in smokers and in elderly. They are seen in patients that are in a poor condition and who breathe superficially. On a chest X-ray, lung abnormalities are mostly present as areas of increased density. However, sometimes they can also be present as areas of decreased density. Radiologists use many terms to describe areas of decreased density or lucencies within the lung, like cyst, cavity, nematocell, emphysema, bulla, honeycombing, bleb, and etc. Many of these terms are based on the pathogenesis of the abnormality. A more practical approach is to describe areas of decreased density in the lung as cyst, lucency with a thin wall; cavity, lucency with a thick wall; emphysema, lucency without a visible wall. Cavities frequently arise within a mass or an area of consolidation as a result of necrosis. In the differential diagnosis, there is overlap between cavities and cysts. Cavities can heal and end up as lung cysts, and lung cysts can become infected and turn into thick-walled cavities. Sometimes emphysematous bullae have visible walls that measure less than 1 millimeter. To differentiate them from cysts is to look at the surrounding lung parenchyma. Cysts occur without associated pulmonary emphysema. Cysts usually contain air, but occasionally contain fluid or solid material. The term is mostly used to describe enlarged thin-walled air spaces in patients with lymphangioliomyomatosis or Langerhans cell histiocytosis. Thicker-walled honeycomb cysts are seen in patients with end-stage fibrosis. In most cases, by using the pattern approach, correlating with the clinical history, we should be able to identify the most likely diagnosis and differential diagnosis. But before we conclude, never forget to review the old films. It is extremely important to always compare your films with old ones. Was it there before? Has it got larger or smaller? Is it unchanged? A lung mass that hasn't changed in many years isn't cancer. Chest X-ray interpretation becomes easier if you approach it systematically. There is no correct way to analyze the radiograph. You should create your own strategy. That brings me to the end of the presentation. Thank you for your attention.